All right, I'd like to kick off our final session of AHA 24. As we were preparing for our entire event, I was saying that we are starting with a program on pediatrics, which we did yesterday, and ending a program on geriatrics. We've had students as well as deans. We've had patients as well as clinicians. We've talked about the last 100 years, but we've also talked about the future. We've talked about community health, and we've talked about AI. So we've really talked about everything. So thank you all for staying. I know this is a tough time because people are trying to see what their flights and their traffic is going to be. Remember that we are on camera, so we'll have a video of this either way. So with that, Jared, go ahead and start.
Okay, thanks so much. My name's Jared Magnani from the University of Pittsburgh, and I have the charge of starting this great, wonderful session on innovating cardiovascular care for an aging population. Great. So this is going to be introducing a panel that will be Dr. Dan Foreman, Dr. Elizabeth Joy, Dr. Christopher O'Connor. Erica Spatz won't be here today, so I'm going to be taking her place and providing the clinician's viewpoint. Following that, we'll have an additional panel here from Kelvin Health, Gorky Kadrov, and Ivo Petrov, Dr. Ivo Petrov. This is not my presentation. Let's go back here. Okay, we're ready to go? So we're going to be talking now about cardiovascular care for an aging population, innovation, and future directions. And as many of you are aware, we're seeing a real global shift in terms of age demographics right now. And for the first time in about the year 2060, what we're going to see is that there is an intersection point in terms of the number of people who are age newborn to age 14 to those who are age 65 and older for the first time in our world. And what that means is that we have an older world, a graying world. In the United States, it's really profound in terms of seeing that for the first time in about 2034, we will have more older adults, those who are over 65, than we have children. It's an inflection point in terms of the aging of our country. The population is aging, and the number of kids is decreasing. And that means a huge shift in terms of cardiovascular health and health priorities. We know that age is the most prominent risk factor for cardiovascular disease, and age also travels with comorbid conditions like hypertension, diabetes, dyslipidemia, and other comorbidities and other insults. And so what we're trying to do most effectively is to address age-related risk factors, and we talk about this compression of morbidity into more advanced years. Here we go. Let's catch up. So this is the inflection point here where we see that we have an aging world, and right now in about the year 2060, we'll see that these cross. And here in the US, we can look forward to the year 2034, when for the first time we have this inflection point as well, and we see that there is a huge shift in terms of demographics. And if you look at the population distribution from the census between 1960 and 2060, you can see that it's really compressed from this being this pyramid-shaped, this funnel-shaped, to being this pillar. And that's what we're seeing now. Age, we see that cardiovascular disease is a disease of aging, and with this multimorbidity and the introduction of risk factors over the life course, we have more and more events as people age. And I mentioned this compression of morbidity, this capacity to extend lifespan and extend what Dr. Dan Foreman here frequently reminds me, which is health span, years of longevity and years of living in a healthier way by delaying the onset of cardiovascular disease. But we also heard the competing tension here at this meeting in the opening session, which if you look at the 2024 AHA statistics, you'll see that the risk factor in terms of the prevalence of diabetes and hypertension, dyslipidemia, it really is going up more and more. And so we have uncontrolled risk factors. And so what this means for us is an increasing burden of disease, increasing healthcare utilization. How can we actually address that? And is technology an answer? Well, the people who are growing older now, they have seen the technology timeline, and they've seen a span of intellectual and technological engagement and possibility over the course of decades, such that they now have access to new software and new applications, new technologies that certainly weren't available even just such a short time ago, let alone over the course of the decades. There is this kind of concern that has been present about the what's called the gray digital divide, and this is the fact that we expect that older adults will be more uncomfortable, have less capacity, less familiarity with digital devices. Just a brief anecdote from my life is my mom with my daughter sitting, and I remember about a decade ago, my daughter explaining, "Grandma, you don't have to hit the phone so hard. You don't have to hit the screen with your finger. You can just tap it. You can just lightly set it." And so what we see is that this gray digital divide is closing as internet use is more and more prevalent, and also broadband is far more prevalent across age groups. And maybe this is because of familiarity in terms of comfort, and also because in our society, how many screens do you see people using every single day? I look at the audience and I see that so many people here have their smartphones out while we're talking. And so they're multitasking. And if you look around this meeting, you can see that it's just ubiquitous. Go on the L or the bus here, and obviously you see the same thing every single day. How many hours do you and I have in front of screens, and our patients as well? So there is this kind of socialization, and that in turn has also closed this gray digital divide. As people have become more and more familiar as they're older, of course, they've adopted all the technology that's available. And as you know, once you go forward, you don't go back in terms of how it facilitates taking care of things, and also helping you with tasks and helping you with the mundane stuff of life. So we have an enormous health technology that's now available for monitoring older adults. And this comes from a great review article and summary in Nature Medicine. And what they point out is just the huge amount of capacity for monitoring that's available in different conditions. And so on the upper row, you have obviously the Apple Watch, and there's the Aurora Ring, which monitors biometrics. And I just learned about a blood pressure monitoring ring that's being used in South Korea and is advancing forward. And then there's devices to measure balance, to help with sleep, for continuous monitoring of metabolites. And so there are an enormous amount of data that are being used, and they can be used and marshaled to help people with aging-related diseases, cognitive disorders, age-relating brain disorders, cardiovascular disease, and hypertension in terms of monitoring. And obviously, there's just a host of applications, and these are multidisciplinary, and they can assist with balance and foot problems and mobility as well. So there's just this kind of array of stuff. If you think about what the home might look like, we could have a robot, we could have a pet robot, we could have all these devices that interface and that allow us to measure and to follow a lot of clinical indices that are relevant towards people's aging healthily in their homes. I think one question is, with all of this, would you like to live this way? Would you like to be hooked up like this and to have this kind of continuous monitoring? And how does the consumer interpret this? How do older adults experience this? Is it invasive? Is it an asset to be able to have remote caregivers and digital mirrors, all these home sensors available to you in a home that's networked like this? It really raises important questions, I think, that we can talk about today. So some of them are really, I wanted to focus on 5 distinct challenges in terms of applying this technology. The first is pretty obvious. We've talked a lot about health equity and tech equity. People use the term tequity because, of course, this is expensive gadgets, right? Secondly, it's access and affordability. So who really can afford this, and are we actually, with some potential, we're shrinking this gray digital divide, but we also have a health tech divide now that we're introducing too, which is based upon people's social resources. And then there's device literacy and who can actually use this. And, you know, I brought up grandma, but so we have to train our patients, and people have to know how to interpret it. They're getting a lot of noise thrown at them as they have all of these data available to them. I had a patient, as I'm a general cardiologist, come to me and say, why is it that I'm now pacing 4% of the time as opposed to 1% of the time? And we have to discuss that. And then I think there are a lot of data here, but are they meaningful? And are they meaningful for patient care? And this kind of suite that I showed here in this far-flung future of the wired-up home, is all of this really meaningful, and who is going to be using it? And I think that me, as doctors, as caregivers, as clinicians, we have to be able to distinguish the signal from the noise, obviously. And then I think that there are psychosocial challenges that we really have to consider, which is, what is the burden of ceaselessly monitoring people? And so does that, like my patient who has their pacemaker and they're able to see the reports of the interrogation, are there challenges here, psychological challenges that people experience when they're being monitored like this full time, 24/7? So I'm really interested in us moving forward and discussing some of these and some other questions. We're going to have the panel now. I'm going to be a part of the panel. I'm an associate professor of cardiology at the University of Pittsburgh. I'm also a researcher who uses mobile health, and in particular to address structural factors that impede access to care. Dr. Elizabeth Joy, the Chief Medical Officer for Lore Health, will be a part of our panel. Dr. Christopher O'Connor, who is the CEO of First History, a really novel company that facilitates history taking, will be a part of our panel. And of course, my colleague at Pitt, Dr. Daniel Foreman, who is a cardiologist and geriatrician and brings really sharp expertise from both domains. Thank you so much.
So great. I'm Dan Foreman. I'm going to let the panelists respond to the introductory talk and learn a little bit about their reactions and a little bit about their companies and their perspectives that brings to this moment for us. Actually, Chris, would you please start? I think you will talk a little bit about process and the interaction, interface with the AHA, and then I think that'll lead to our next comment after that.
Okay, great. Thanks. That was a great oversight. The answer is this is complicated, and getting this right is going to be, I think, one of the major challenges of clinical medicine in the next 10 years. There are so many different moving parts to it. There's lots of tech out there. I think the challenge will be to use this tech intelligently and sort the hype out from the reality. And I think it illustrates the need for careful health tech evaluation. I think that's going to be super important going forward. And the other comment I would make is the American Heart Association and the guidelines, thanks to Pat Dunn and what they've built there, really is the foundational knowledge that's going to make all of this impactfully beneficial. And so I think that's important. Quickly, in terms of First History, we've built a digital twin of clinical knowledge. So the scientific knowledge, the experiential knowledge, the health system knowledge, such that we can do a key process, which is interviewing individuals, in this case elderly individuals, on their smartphone at home with an adaptive knowledge-based approach. And so that empowers them to tell their story to the healthcare team in an effective way, saves time, improves quality, et cetera. So yeah, an area of huge promise, I think.
And just to respond to that, the geriatricians for over a decade have really preached about for 2 or 3 decades, have preached about the value for a comprehensive geriatric assessment. knowing everything about an individual, including family dynamics, including all kinds of personal goals, is a fundamental foundation of care. And yet it's singularly inefficient to obtain that. Hours and family assessments, and it goes on and on. So as you talk about, this sophistication in digital care, do you think you're going to provide that comprehensiveness in a way that's more efficient and achievable?
Well, I think you raise an excellent point, because the traditional approach, which your great-grandmother would recognize, by the way, is an unstructured analog interview where the clinician asks questions, the patient gives an answer. As we know, that process is time-consuming and can be challenging in everybody, but particularly for an elderly population that have even more comorbid conditions. That collecting all the core data they need is an enormously challenging process. And so can we use digital intake of this information both to speed up the process? In Y Company, we improve efficiency somewhere between 25 and 50%. Can we comprehensively collect all the data that you need, ask all the questions, all the risk scores, all the calculators that you need to do, cardiac, Has-Blood scores, that you can do that in an automated way, and then present that to the provider or clinician in a structured way that then makes it easy for them to start caring for the patient. And so get the computers doing what they're good at, routine and regular, and then that sets up the stage for the physician to focus on that which is unique about each patient, because we know every patient does have unique things, and you want the two working together.
So our next panelist, Elizabeth Joy.
Yeah, I really appreciated the presentation to kick us off. And, I think about this narrowing of the digital divide with respect to age. And up to 90% of older adults are accessing the internet. I mean, it's as normal to them as it is to my children, who are on it constantly. And about 2/3 of older adults have smartphones. And when we talk about even our vulnerable patients, so vulnerable seniors, most of them are accessing the internet from their smartphones at home on their home Wi-Fi. And so all of those things, I think, are contributing to that narrowing of the digital divide by age. And as it relates to LORE, and I'll talk about that in just a minute, I read in a recent McKinsey report that 70% of 70-year-olds are accessing online communities for social connection. And now that we have recognized that social isolation and loneliness are a major cardiac risk factor and contribute to premature mortality, I mean, if we can connect people to people and people to ideas, we have the opportunity to kind of create new social norms around what is healthy. And when people were isolated before the pandemic, and it only was accelerated by the pandemic, and it continues unless we really start to leverage technology, in order to achieve scale when it comes to addressing cardiac risk factors, with heart disease being the #1 killer. And that really was what led us to develop LORE. And LORE, like many others, is part of CHTI, is a health technology company. We seek to help people improve their mental and physical health. And I think the important part is the daily practice of healing. People need daily healing to address all the stressors that they're dealing with. It may be related to their health, their children, their families, their job, their circumstances, their finances. All of those things, result in the behaviors that they then engage in, right? And what do those behaviors look like? Well, it's emotional eating. It may be being more sedentary for any number of reasons that relate to aging. They have mobility restrictions. They have a fear of falling. All of that comes with lots of different emotions, around fear and shame and guilt, etc. And so what we've built at LORE is a platform, an application that includes a generative AI bot that is working off a large language model. And the bot is trained to do something called reverse prompting. So unlike the bot at Nordstrom's that answers your questions about shoes, this bot only asks questions. So the bot can never get in trouble. So the bot is constantly inquiring about the choices you're making, how you're thinking, how you're feeling, what are you exploring, what are you experimenting with, how are you succeeding, how are you not succeeding, and then rinse and repeat. We also connect people then to an online social community with thousands, soon to be tens of thousands of people. So connecting again, people to people to ideas, creating a social community that has strong social norms around health and gratitude and support. And then last but not least, we also have a built-in extrinsic reward system. So Loar's clients are payers, healthcare systems, and employers. And we have a risk model that also provides us with the opportunity to pay people up to provide people, I should say, up to $600 a year in financial rewards. And again, as we're working with older adults, particularly vulnerable older adults, that $600 is provided to them in the form of a grocery gift card, which now is helping them to address food insecurity. And in a recent patient interview that I did, I asked a woman, she is 72 years old. She is still working as a consultant. And I asked her, why did you join Loar when you were provided the opportunity through your healthcare system? This is a pretty healthy 72-year-old. And her response to me was, well, duh, the money. So, extrinsic motivation only goes so far. Eventually, you want to get people to that kind of intrinsic place. But the extrinsic is a great fire starter. And so, we're really trying to move upstream in terms of addressing things like self-awareness, self-regulation, self-efficacy, resilience. Those are all the things that drive the behaviors, that drive the disease, that result in heart disease.
Great. So, and I've not been invested in technology in my own career, and I'm very happy to be part of this session because it really informs the opportunity not just to improve the physician-patient exchange, which is a huge opportunity to increase the efficiency of health data acquisition, but it changes the process of care, which is what you're speaking of. It's a transformational perspective. I want to talk about or acknowledge that the geriatricians have not really been successful. There are too few geriatricians to be truly impactful to the clinical need that Dr. Mamdani already described. Our population is growing, the number of geriatricians is inadequate and shrinking in many places. So there's a paradox, and I think having this technology, this transformational opportunity, is not only great, it's essential, because otherwise we're really going to have a complete gap that's only going to get worse with terrible consequences. So I think this is very exciting. Jared, do you have added thoughts from a clinical perspective?
So I think we can innovate, and we can come up with great tools that we can then implement with older adults. But I think one of the questions that I have for my co-panelists here, as well as for you, is how we do this in a way that it engages people who are the end users, so that we construct tools that are practical and that are accessible to this audience.
Yeah.
So that's a great question. It's interesting. I'm really glad you brought up the part about the gray digital divide. One of the pushbacks we sometimes get is older individuals will not use it. They don't have smartphones and they will not complete this kind of thing. And that is absolutely not true as part of your data. I find that's actually an example of anti-elder bias, because our experience is that the completion rates of our history intakes are exactly the same across all age demographics. And we have patients over the age of 95, and they have the same completion rates as the patients in their 50s and in their 20s. Because, one of the concerns of elderly people is certainly their health. They care, they're engaged, and they will use technology. So I think the two key things for technology in this group is solve a problem that's relevant to them, so relevancy matters, and then I think two, have a good UI UX experience. So they won't put up with crappy user experience. They do need things that are built well. But if you build it well and you solve a problem they care about, they will absolutely adopt it.
Just to comment, because build it well, I think you have, maybe you're saying this, but make it for someone who's visually impaired. so that the font is large and it's accessible, make it so that they can hear if they have sensory hearing deficits, making it so it's achievable if somebody has a tremor. I think those kinds of things. I know that Ford and American car companies struggled with this because they had technology for older adults, which they were reluctant to use because it wasn't considered to be, quote, sexy enough. And so there was a delay in actually achieving the utilization of technology that was really perfect for an older population driving. So I feel like this is an opportunity to be, quick and to really design these features as just standards of best use for an aging population.
Absolutely.
Yeah, and I'll add that certainly there's been some skepticism when we talk with potential partners about whether or not older adults will actually use a platform, that includes a bot. Like, what's a bot? An online community. Do they really want to do that? And our experience also has been that, really pretty exceptional uptake. We have a Medicare Shared Savings Program, accountable care organization, and we have enrolled practices from all across the United States with a focus on federally qualified health centers. And we also include a large inner-city academic medical center. And I think close to 40% of the people in our ACO are also dual eligible, meaning they're on Medicaid and Medicare. So this, is a population, that is thought to have lower health literacy, lower digital literacy, higher burden of disease, more unmet social needs. I mean, so many challenges. Like, they're going to use, an online application, and the answer is yes, they do, because it's solving a problem for them. Yeah. One of those problems is the social connection, right? 70% of 70-year-olds use it for social connection. But it's also providing them, with this kind of pragmatic learning, the people like them phenomena. I mean, I could just go on and on about that, but we have about just under 20% of people who are eligible actually create an account and use the application, which, what I understand, I'm relatively new still to the tech world, but apparently that is an outstanding uptake, particularly for vulnerable older adults. So, we should make no assumptions that, the tech doesn't work for this population, but to your point, that user interface, if it's not super clean, forget it.
Right. Actually, as I'm listening to you and the other panelists, I would use the word empowerment. You talked about social connection, but it's the avoidance of isolation. There are many things that people fear, in my experience as a geriatrician, as they age. But if you have a resource that can really moderate that, which you do, you're all thinking about it, and you really sell it as not just a gadget, but as an enhancer, I think that's a way to really get a lot of interest and a willingness to try this. Even though it might be a challenge, it's worth it, I think, for most people.
And I'll also address that, we have the ability now with AI to be able to help overcome a lot of challenges, of diverse populations. So although LoRa is optimized for the smartphone for many reasons, it's also available to people on a laptop or desktop, which makes it easier for others. We also, integrated, just about, I think, almost any language, I think except maybe Japanese, Chinese, and Russian, because of the characters, is hard to do in the text. But people can converse with the bot and with the community in the language of their choice, which has been great since, many of the populations we work with are predominantly Spanish-speaking.
Could one of you speak about the AHA interface? Because I just learned about that today. So I feel like we're providing potentially patients with information, but it's information that's been vetted by the AHA. It's informed by the guidelines. And so I think it becomes a particularly enriching resource with this kind of interface that the AHA is shepherding.
So absolutely. So, as I said, like a shout out to the AHA, because look at this conference here, the incredible knowledge that's been developed here, the AHA guidelines, and they've got a great process for vetting the scientific evidence. And so that really is the source of truth that will help you get the treatments that you need. So that's the first stage of the journey, and it is foundational. It's the scientific knowledge, and having the AHA as a resource for that is foundational. And then the next stage of the journey is, making the diagnosis, finding out if those treatments are appropriate for a patient, and that process can be complicated, and that's why we've got why we take histories and why we have physicians to sort all of this complexity out. And then the final leg of the journey is getting the treatments and then seeing if the patients actually adhere to the treatment. So you need that full cycle, but it has to be all of it. The foundation that spans all of that process is the AHA guidelines.
Yeah. And if anyone in the audience has questions, I'm really hope you please raise your hand. I'd love to have you involved. But I also have one other question in the meantime. Do any of you have thoughts about the physician or the variety of caregivers involved and how they should use such an interface more effectively? Because it's bidirectional, and frankly, I think coaching the patients to use this and to engage with it, I think, comes from the provider as well as the patients.
Yeah, I could touch on that a little bit. The average face-to-face time for an outpatient visit with an adult primary care provider is 18.2 or 18.3 minutes. That's not a lot of time. It turns out the provider has an agenda. There's all those pesky quality measures that we have to do. The patient has an agenda, and maybe they have other questions or concerns that weren't even thought to be a part of that visit. So when do we get around to talking about physical activity, diet and nutrition, sleep, stress, risky substance use, social connectedness? For most visits, it doesn't happen at all because there's just not time. And so, I have said for at least a decade, people do not get well and stay well in the doctor's office. They get well and stay well where they live, learn, work, play, and pray. And that's totally stealing a line from Howard Koh when he was Assistant Secretary of Health and Human Services. But the point being is that, we need to support people, in the 99.98% of the time they're not in our office. That's where they're making hundreds, thousands of decisions and choices every single day. And the most powerful thing they have is this. Yeah. They're carrying it around in their pocket, right? And how do we optimize that in such a way, that it's not distracting from their quality of life, but it's actually supporting their quality of life? Thanks for the prop.
Yeah, and I would just, go ahead.
You can go ahead. Why don't you start?
Yeah, I think it's part of that continuum. Like the journey starts when the patient is going to go see a physician or a healthcare provider, and the ability to get the detailed information out of them that's going to provide the foundation for their care. It starts with preparing them for the interview. Patients don't know what we're going to ask them. They go into an interview completely unprepared. It may seem obvious to us if they've got a headache that we're going to ask them about when their headache started. It's not always obvious to them, and they certainly don't think they're not aware of the negative symptoms, the things they aren't going on that might be important. So they come in unprepared. So by going through like First History, a digital twin, they get asked the questions they're going to be asked that helps prepare them for the interview. Then it deals with this issue of extreme time shortage, which is a real phenomenon due to all the history of present illness, past medical history, allergy, medication, social determinants of health, and functional status. Like, really? And exactly, it doesn't happen. We know that that's a challenge, and so we can get that. Then we can get the history, which can then drive the processes downstream from that.
We have a very fractured healthcare system. So you and I have a lot of patients who see a lot of different doctors. If they're fortunate and they're an older adult, they get to go to a geriatrician, in which case they have somebody who could think about them in a more systematic and comprehensive way, and not as if they're just a bunch of organ systems. So I think that there's potential here to find ways to create, to span and incorporate a multidisciplinary lens.
Yeah. No, these are great points. The other thing which comes to my mind is the notion of the shared decision making. I mean, the geriatricians talk about shared decision making, and the AHA has embraced it, and others, as something which we should all be doing. And I think, to actually achieve that, I think is much easier said than done. And so shared decision making implies that the patient has been informed, that is aware of the other choices, that someone's really taken the time, and abstract ideas are hardened to things that are more accessible. So I think some of these tools and opportunities may provide that as a more likely goal to achieve.
Yeah, I'll add that one of the things that we do is recognizing that the empowered patient who is taking charge of their decisions and of their health, then they become more informed, and it makes for a better provider visit. You know, they go into that visit saying, you know, I have been walking more, I have been sleeping better, I am managing my stress, I've been wearing one of those CGMs, you know, and I've noticed that my glucose levels are a lot lower. And what we're seeing in our population is some de-prescribing actually happening, you know, with that empowered patient going into the office and actually sharing, you know, I'm doing better, I've lost weight, I am more active, my glucose levels are lower, and I don't think I need these medications. So, you know, that's putting money in their pocket. I mean, one of the things we haven't talked about at all here is cost, right? And the cost of healthcare just goes up and up and up and up and up. And, you know, that's driven by, you know, the fact that we're not exactly getting healthier. We've got 10,000 people turning 65 every day.
Yeah.
And, you know, that comes with all sorts of conditions and, you know, various comorbidities. But it's really expensive, and it's money out of people's pockets. And if we can, you know, we can try and drive down the cost of medications, we can try and decrease length of stay in the hospital, and those are all things that are important. But I think the most important thing we can do is make people healthier. I dropped the mic, but.
Exactly. I'll just make a quick comment. It's interesting. So I'm a internal medicine critical care physician. I'm not a cardiologist. The two biggest surprises of this conference for me were that, one, there are only 15,000 cardiologists in the United States. And that's a shockingly small number given the number of people. And then the next really shocking number is that there's only 7,000 geriatricians.
Amazing.
And that 50, I mean, wow. And so I think there's a real issue in terms of the capacity to deal with what's coming down the pipe. Like how the capacity challenges here are enormous. And then you look at the complexity of that diagram of all the devices on all of this additional information that's coming our way. Like, how are we going to meet the challenge of taking care of all these elderly people? That is an enormous thing. And so I think the answer to that is the status quo will not do. So the old sort of way where you go see your physician once, and then no contact between visits and totally fragmented siloed care, which is kind of the current status quo, that is not going to work. If we're still doing that 10 years from now, we're going to have a big problem.
And there are many industries that are seeing the aging population as a target. So this population, which has really inadequate physician services and caregiver services, is getting pummeled with advertisements. As we all see every time you watch the news, it's just about, you know, health services that have a heavy price tag. So I think that it's really quite confusing to most older adults, which is why I think the AHA endorsement is actually maybe a very good thing to have, sources of knowledge that may be useful.
It's more important than ever, given all of the disinformation online.
Right.
It's not even necessarily online, by mainstream people in our society
Yes.
who do not validate scientific reality, that it is more important than ever that we have the organization like the AHA to create that ground truth. I think that's critical.
Do any of you have thoughts about, like, the paranoia that somebody, like, Dr. Magnotti made the point about the fact that people are being wired in every dimension of their lives. You know, how many times they sit on the toilet and how many times they brush their teeth. I mean, suddenly it's all accessible. And who's seeing this? And is this empowering, or is this a source of anxiety? And how do you feel that this information should be cared for so that it really becomes a value and not a threat?
So I'll start, and I think there's big problems for the user. There's big problems for how these data get integrated into an electronic health record and into patient care. So for the user, this is a data tsunami. You can be wearing all kinds of gadgets and wire yourself up and monitor yourself and get a lot of meaningless stuff at the end of the day. And so the patient I talked about is somebody who just has access to their record, where she can look at the percentage of time that her pacemaker is firing, is helping her heart beat. And she's troubled by seeing a change in a number that has no clinical significance, but it's a change in a number, 1% to 4%. So, it's time out of the visit, as you both have talked about, helping to educate the patient about this, and that it doesn't signify anything, and it's not a clinical concern. And so it also detracts from, addressing other relevant clinical matters that the doctor has as his agenda for this particular patient. And then I think that what we have is this kind of wired, gadgeted group of people, like the AFib detection on the Apple Watch is a great example of this, which is a lot of people whose Apple Watches are telling them that they're having the heart rhythm disorder atrial fibrillation, when really it's that they're brushing their teeth, they're shaking their arm, or some other artifact, and it doesn't have clinical relevance. And so are you going to have a healthcare system that is somehow going to import this, organize these data, somehow find a way to use natural language processing or some type of AI in order to identify that which is relevant and that which communicates something of clinical value? We're really overwhelmed by any type of home-based monitoring system in terms of really identifying what the actual signal is. It's tough.
It is tough.
Yeah, I think it's an underappreciated aspect of AI as they push it out to the general public, this problem of false positives at scale, and understanding the nature of Bayesian probability, and that a positive test result in a low prevalence population is almost certainly a false positive, which was less of a problem when only your individual physician or provider could do it. But if we can now run that across 100 million people in the general population, it creates a lot of false positives. And I think that's just one of the many issues, I think.
And I guess I'll just add one point that's a little distinct from this, and that's around privacy. And we definitely have patients who check in with us as to how private is the information that they are sharing with our conversational agent, the bot, as well as things that they share in the community. They're all anonymized with an anonymous screen name, but definitely get some concerns. Older adults are told constantly, don't get scammed by this Medicare or that Medicare, and they want to make sure that if they're going to engage with some type of smartphone-based or online resource, that it is private and secure and it's not a scam.
Any final words from anyone?
We just have a lot of work to do, and it has to be highly collaborative.
I agree 100%.
Me too.
All right. Well, thank you very much.
Thank you. That was great.
Thanks a lot.
Yeah, it was so nice to meet you.
Okay, before we start the second panel, to give you a break, we're going to do a brief presentation from one of our innovators who has some very amazing imaging technology. So,
hello, everybody. I'm Georgi Kudrev, co-founder and CEO of Kelvin Health. In the summer of 2018, shortly before my son was born, my wife and I were devastated when her father, Hugh, nearly lost both of his legs because of late diagnosed peripheral arterial disease as a result of his diabetes. And 2 years later, in the beginning of the COVID-19 pandemic, we got exposed to a very accessible hardware, this mobile camera for thermography capturing. And we decided that this is a great opportunity to utilize our previous experience in image recognition to create a diagnostic solution for PAD that is very accessible. So this is how we started our collaboration with Professor Ivo Petrov and his medical team. And I'm excited to give him the word to explain about the clinical experience that we have with this technology.
Thank you, George. dear colleagues and friends. It's my huge pleasure. So I will speak about thermography, artificial intelligence saving limbs and lives, my possible conflicts of interest. Speaking about peripheral arterial disease, this is one of the worst signs for cardiovascular and cerebrovascular disease and their complications. Both myocardial infarction and stroke are much more often among the patients with peripheral arterial disease as one of the main signs of atherosclerotic process. And more than obvious in the aging population, we need a screening tool that has to be reliable in order to catch the early stages of the disease. As it's obvious, palpation is not the best one. What about ankle brachial index? Both in American and European Society of Cardiology guideline, the ankle brachial index is in the guideline as one of the main baseline tools for screening of peripheral arterial disease. Unfortunately, it's inaccurate in diabetics because of mediocalcinosis, and also in patients with end-stage kidney disease, it's definitely not the best tool. It's clear that we need another tool for this very important screening. It has to be non-invasive and safe, quick and reliable, non-operator dependent, and possibly cheap. And in our opinion, this is artificial intelligence assisted high resolution infrared thermography. Speaking about thermography, for example, the temperature is one of the most important features in the medicine at all. So Hippocrates more than 2,000 years ago told us that should one part of the body be colder or hotter than the other, disease is present in that part. So the idea of using thermic images came from astronomy and went through military application and also the construction, the technology, and finally came to medicine. So speaking about medicine, as early as in the 40s of the last century, in fact, the thermography was applied for the first time in as a medical application. For example, in this publication, it's shown that both before and after intervention, there is a correlation between ankle brachial index and high resolution thermography. As you shown on the C panel in this picture, you see that definitely the left lower leg, left foot is with lower temperature and hence lower perfusion. Speaking about the technology of Kelvin Health, this is in fact a high resolution camera, thermographic camera, that is assisted by the artificial intelligence elaborated by the algorithm of deep neural networks and also spatial temporal prediction and segmentation based on angiosome principles. So these are the segmentation of vasculature. And on such a way, we can guess about the perfusion of the underlying, under the skin tissue of a particular patient. We have spread the technology over 3 continents, and many very well-renowned specialists in Argentina, UK, US, Bulgaria, Greece, with the application of this very, very promising technology. We validated in more than 2,500 patients already the technology, and we have checked the sensitivity and specificity in comparison to both ankle brachial index and angiography. That is, in fact, digital subtraction angiography is the golden standard to show vascular pathology. And we have found extremely high sensitivity reaching 100% depending on the vascular territory, and specificity between 80 and 95%. We have elaborated multiple publications, and for example, several pictures, several cases from our practice. For example, I'm asking you, can you guess what is the underlying condition behind this lacking perfusion of lower legs? Those of you who suppose that this is Leriche syndrome, occlusion of the aorta, you are right. Yeah, this is the picture of total occlusion of the aorta of this gentleman. This is another case of left lower leg acute ischemia detected by thermographic images during the night after an endovascular, otherwise uncomplicated procedure. But during the night, this patient had a pain on his left leg, and this thermographic picture with lack of perfusion on the left leg was confirmed with the angiographic result on the level of the left common femoral artery. And what happened after the recanalization and endovascular stent implantation? And as you see, full restoration of the flow of the left leg. And this is the result. Full restoration of the flow and equalization of the picture between the right and the left leg that was lacking perfusion. Another case, this is a 75 years old with quite a dramatic history of amputation of left lower extremity, and he presented in our clinic in stage 4, Rutherford, with extreme right lower leg ischemia. As you can observe by the angio, there is a practically almost complete lack of perfusion, and also you see the missing left leg and the suffering by hypoperfusion right lower extremity of this particular patient. Speaking about segmentation, and this is the proof that the segmentation of our technology is absolutely reliable. So after partial restoration of the flow into the popliteal and peroneal artery, we have this result. And after the full restoration in all 3 vessels below the knee, we have full restoration of the flow also on the thermographic images like seen in this perfusion. And what about cerebrovascular, carotids and stroke? So in this particular case in which the right external carotid artery is practically totally occluded and subtotal occlusion of the right internal carotid, it's very well seen that the territory of both arteries in blue and gray are with lack of perfusion. And this is the result after the recanalization and stenting of the carotids, both carotid, and you see excellent restoration also of the thermographic image on the skin. Even more dramatic case, this stuttering stroke patient with subtotal stenosis of the left internal carotid artery. This is before and after the stenting, after recanalization, and this is the full restoration of the intercerebral flow of this particular patient with excellent restoration of the flow, and this is before and after the implantation of the stent, before and after the restoration of the intercerebral flow in this particular case. So obviously, it's the technology is applicable in multiple vascular territories, and probably one of the most important details that is extremely fast and reliable. So with the utilization of artificial intelligence and thermography, we can skip very important steps, time consuming, that can lead to delay into the treatment of a particular patient. And this is very important to go faster to the right decision and to the right treatment in any particular patient. What is in the future? For us, in the future is that. So spreading out the technology, user-agnostic screening tool for general practitioners, non-vascular specialists, but why not also in-home use and remote monitoring, for example, into the ambulance for patients with stroke, for example, for early detection of the problem. as a take-home message, I would say that the thermography with the artificial intelligence assistance is a non-invasive, radiation-free, time-saving method that is detecting early changes and enables us early detection, intervention, and follow-up of the patients. And this is our team that is, in fact, collaborating very well for the improvement of this very, very promising technology in the future. And thank you very much for your kind attention.
Thank you. And last but not least, our final panel. Come on up. There you go. Are you going to be at the podium? or
I'll
are you
stay,
gonna...
yeah, because there are 4 people, so.
Okay.
Do we even have our other? Okay. Can we start, Pat?
Yeah, go for it.
Okay, great. Well, thank you. Grateful to be here moderating this session today. Thank you to our panelists, Erica Shore, University of Minnesota School of Nursing. I'd like to start by letting each of our panelists briefly introduce themselves, and then we will pick up off of where the panel 1 topics left off.
First of all, thank you
Okay.
for Pat Dunn to give the opportunity here. Nice to meet all the panelists. So I would just give a basic introduction. I was associate professor with University of Texas. I think this is still like a older thing which hasn't been updated. I moved on to start a new healthcare innovation startup using voice AI in medical clinic space. Happy to be part of the panel.
Thank you.
Hello, everybody. My name is Yair Saperstein, and I am CEO and co-founder of AVO. I'm also a hospitalist and an informaticist, and it's a pleasure to be here.
Jamie Edwards.
Oh, with the mic that's off.
All right. Check.
No. Here,
All right.
how about?
I'm Jamie Edwards. I'm the President and Chief Strategy Officer at a company called Karen's Health, which is an artificial intelligence and machine learning business where we are deploying an AI assistant for seniors and for polychronic patients.
Hello, everyone. I'm Naveen Govind. I'm the founder and CEO of Aventin. We are a digital therapeutics company building and evaluating a whole new class of digital biomarkers for congestive heart failure, diabetes, and kidney disease.
Great, thank you. There are a lot of places I want to go in this discussion, but I'd like to start with a recent result from the AARP. So that's 50 adults that are 50 years and older, and 7 out of 10 older adults don't believe that today's technology is designed with them in mind. So this builds off of the panel 1 comments about the user experience, and that's one of the biggest barriers for them using it. So curious to hear from all of you how you have involved users, consumers early on in the development and implementation of the products that you have.
I can take that question. So we are talking about exponential development in technology. So the study, even it was done like a couple of years ago, things have dramatically changed. We used to talk about something called Murphy's Law, which is like the number of transistors in a semiconductor goes down by 50% in 2 years, and the cost goes down by 2 years. That law has been completely replaced by something called a scaling law. There is a talk from Satya Nadella, who is the CEO of Microsoft recently. So with the exponential rise in AI, the amount of watt power, we currently call tokens per watt. That's a new currency. So that goes up quickly, and we can advance the technology within 6 months. So anything which we talked about a year ago, 2 years ago, it's almost irrelevant at this time. In the future, or even now, the technology done by artificial intelligence and humans is almost indistinguishable. So there is a recent thing where a human talks to AI, and the quiz was, can you pick who's human, who's AI? And we are not able to do that. Same with the images. So in next year or two, there will be a rapid advancement where the elderly users will feel like the technology is suiting them. You know, they would want to use it because they won't know it's human or AI.
The way that I think about it is that there's a difference between the immediate sense and future sense. So when you have innovation, you need to do innovation for the current time, and then you also need to think about, well, where do we want to go eventually? And in the current time, you probably won't meet an elderly person that doesn't like their doctor or doesn't like some aspect of the care that they're getting from other people. And the way that we think about it is that if you can put the right technology into the physician's hands, into the clinician's hands, suddenly you can impact care in a way that will have immediate impact, including on the geriatric population. In the future sense, you know, the other technologies that are directly patient-facing, that allow for the patients themselves, the geriatric patients, to actually impact with technology is something important to keep in mind. And there you do have the change over time. It's, you know, the chart that was shown beforehand about usage of the internet. And, you know, if you take a look 5 years ago, the amount of geriatric patients that use the internet to now, the change is astounding, and it'll continue to have more of this impact where as people get used to technology, including the older generation, they're more likely to use it. So we will have that impact in the future, but for right now, the immediate innovation is put the right technology in clinicians' hands.
I think from my perspective, I've always come from the camp of human-centered design. And I think most founders, when you're building a company, end up trying to build what they think the market wants as opposed to going to see what the market wants. And so the way we've solved that at Cairns is really going about what we call co-development partnerships. And so we have a co-development partnership where we have a $2.5 million grant from the NIH, and we're building out an Alzheimer's use case on the platform with Indiana University Health. So instead of us going out and telling the market what it needs, we're actually doing fundamental customer service research, building a solution to fit a use case that we think is going to have the biggest impact at the point of care. So I think it's about working with all of the constituencies, caregivers, patients, and the clinical teams. And I kind of think we've spoken a little bit too much about patient-centered care these days, and it really should be about human-centered care. And, you know, Yair brought in the clinical teams. I think clinical teams in terms of development have been largely ignored. And we need to realize a lot of the times the patient isn't actually the person who's actually, they're receiving care, but they might not be in control of their care. And so how can we actually change that fundamental behavior is by going and working with all these constituencies together and taking their perspectives into account.
So I'll come at it from a couple of different perspectives. 10 years ago, we presented our remote HF1 study data, which involved remote monitoring of patients using the first generation of smartphones with a collection of Bluetooth-enabled devices that were taking symptoms, different types of vital signs into the platform. The majority of the patients in that 65-patient cohort, which was a multi-center trial spanning India, Sweden, and here in the U.S., were in their late 60s, a typical CHF patient. We found during that study that while we did have good engagement with the elderly cohort, we did have a lot of skew in terms of how the patients interacted with the technology. For example, folks that had problems with their extremities couldn't have the ability to type in or punch in data if, for example, the device was unable to capture that data. The second aspect of it was visual. Visually, some of these earlier devices did not have the capacity to change fonts or provide the best visual display of how their blood pressure is trending or how their weight is trending. So we learned quite a bit from that. So today, 10 years since, that technology that is being utilized today has become that much more easier. for patients to not only use speech, and that had been a huge impediment. Visually, now we can use a lot of multimedia effects. For example, from a congestive heart failure protocol, patients waking up between 6 to 10 are prodded. It's usually that 1/3 of the patient that needs a push. How do you engage that patient? So there are ways and mechanisms where technology has, in our studies, shown that it can show a marked improvement, and has definitely trended in the direction where we've started to see better outcomes of these patients. And I'll talk a little bit more from a cost perspective. While the costs of these technology components were fairly high at the early stage, they have come down dramatically. And not to mention that in the chronic care world, because of some of the codes that have come into play for transition care, for chronic care management, has certainly helped speed up some of the adoption of these type of technologies, so that the population that needs it the most, which is in the elderly category, are able to better take advantage of these technology tools.
Yeah, so cost maybe not such a factor, access, usage, those are old problems, right? Problems not to solve for. I think one problem that persists, and particularly as it relates to AI, which many of you are in that space, is issues that consumers have over privacy and security. And this started, the first panel was discussing this, and curious to get your thoughts on that challenge and how your companies are approaching it.
I can start on that one. So I think in many industries outside of healthcare, people have traded privacy for convenience, right? We've done it in financial services, which we consider that data really valuable. And clearly being HIPAA compliant in the healthcare world is important. But there is an expectation in terms of, we're a voice-driven AI agent. We put patients in context using Radar, so we're continuously monitoring them. But that's their expectation of us. And that is much different than their expectation of Google or Alexa, who they feel like is going to take their data and sell it and try and target them, for a device that they might want to buy or a service they might want to buy. I think the difference in the level of expectation is that we're there to care for them. And so as long as we are doing everything we can to keep information private, SOC 2 compliance, HIPAA compliance, high trust certification, that the rest of it is the natural trade-off, and people actually expect us to know this information. And one of the things that we've taken a look at, because we're using Radar, is that the ambient sensing isn't as invasive as having a camera in somebody's room. And so we've been doing as much as possible, because all the information that comes out of that data, for all intents and purposes, in our database is all redacted information. And so I think there's less fear with tools like that.
Thanks, Jamie. That makes sense. Is that a similar situation for others?
We're a clinician-facing AI, right? So it doesn't matter as much if patients would readily give up their privacy. I think about like Apple Health as a corollary to what you're talking about, where it's like me as a patient, I'll take off the doctor hat for a second, but me as a patient, I can give up my right to having protected health information because I'm allowing for Apple to access it. Very different for us, where we are a clinician-facing tool, right? It's like one of our tools is effectively ChatGPT in the EHR, where it has access to the patient info. You can ask whatever questions you want against the EHR data, against the guideline data. And so you can say like, oh, am I up-titrating correctly for my patient's hypertension, right? And get that kind of complex answer. The thing is that there's the expectation at once that that will be secure, right? So we have a BAA, we have a zero retention agreement, like all of these privacy policies in place. We also have security in place, so like SOC 2 Type 2 to ensure a higher level of security. But besides for that, there is a question that comes up, which is more about auditing and saving it so that you can go back with an audit trail versus the security and the risk of having it for too long in case you can be hacked. And there are these questions that have come up recently over the past couple weeks, couple months, either on one side or the other. Like, how can you not have it for too long because, how can you not have an audit trail? And on the other side, like, how can you keep this patient information forever and then be at risk for these privacy breaches. And it's difficult for these companies to navigate, even more difficult now, right, in the world of AI, large data, keeping this information, to navigate in this middle line and balancing between the two of them. And at AVO, we really try to strike the right balance between having the ability to audit at least for a limited time, and then ensuring that there's this privacy and security to ensure that the patient data is safe.
Unique challenge, yeah.
So I completely agree with you both. Any new technology which comes into practice, like internet, electronic health record, we go through the same cycle. First few years, people are so worried to put their credit card and buy something on Amazon. Still, some of the elderly patients I see, I tell them, like, why shouldn't you get it? And they don't want to do that, you know. Over a period of time, automatically the sense of comfort takes over the sense of privacy rights. So same with AI. AI is a very new technology. Within the next 3 to 5 years, everybody would know what data gets stored, where it's stored, and how private it is. And the companies are constantly evolving too. Like Air was saying, there are BAAs. Like it's same like we send data to Quest Lab. We send the patient info, date of birth, social security. Similarly, the patient data goes to a company which has a BAA with the hospital or the clinic. So it's not very different. So over a period of time, definitely will get evolved, and then like we'll use it more comfortably.
So, you know, you can't come to a health tech panel and not talk about AI now, right?
Right.
So it's become so mainstream, so to speak now, that traditionally in most of our clinical studies, when we do our initial patient recruitment, we go through our consent forms. So we educate the patient. So that's a big word in and of itself. Educating the patient is a lot of time that we take to help the patient understand why they are participating in the study and what's the benefit for them. So part of that has now evolved, and we have this new chatbot, which we have developed for cardio-kidney metabolic disease. So this is a very specific patient population that is going to be a part of this study. And we have a short video that hopefully you'll get a sense for it. So it's right off the plate here. So it's a sneak peek, which basically it's again all about patient education. So it's about encouraging the patient to understand their underlying disease state and why are they participating in some of this. So this chatbot, while it's engaging the patient, automatically gives the patient information about their disease state, and it progresses through a series of questions and answers, so the patient is better understanding the different risks of the disease, understanding if there are treatment options, what are the current treatment options, why are we doing some of these data collection components that are built into these that are happening. So this is at a very early stage, so our patients are going to be using this, and we're going to be educating a lot of our patients. So again, I think this is not any different than doing what we normally already do, which is if you have a BAA, we're conforming to HIPAA, high-tech, and if you're doing GDPR, you're having a lot of that built in. So this is going to that next level where AI is now actually engaging the patient. So we know from a lot of our data that an engaged patient is a more compliant patient. But it's again, education and understanding what the patient's needs are. I think we come at it from that perspective.
Yeah, it's a good first step is increasing education, and we do know that that doesn't necessarily always translate into behavior change, especially when it comes to cardiovascular disease. So knowledge does not necessarily translate into those necessary behaviors. Curious about, we're talking about innovation specific to cardiovascular care, what you see in the future for us, particularly when it comes to older adults with cardiovascular disease. Where are we headed?
So I may be too futuristic, but when you talk about elderly, the overall market or overall way we are going is or there are certain companies who are doing it. Example is Calico. It was by Google. It's a $2 to $3 billion company. Altan is another company who is like, again, $3 billion company. They are all doing studies on anti-aging. So one of the thought processes, if we do not die up to 2050, the chance of dying from natural causes after 2050 is going to be really low, unless an accidental death or cancer-related death. Because the mitochondrial degeneration, apoptosis, is going to be replaced by trials where the patient gets a medicine and then they don't age, which is amazing, right? And it seems successfully they did a study, but they did it on dogs. I think the trial name is Loyal. They did a dog trial, and it increases the age of, increases the lifespan of dogs by 1 year. It's amazing. That's the eventual future. But like Air was saying, we don't want to stuck to eventual future. We want to have a trajectory where we can catch the future, but at the same time innovating for the current era. So we need to do our routine things where we are using AI for the elderly, fall prevention. I saw like a jacket they can wear now. It picks the speed of fall, and then it automatically inflates before the person hits the ground. So there would be no fall-related fractures, which is a big thing in elderly. So similarly, there are a lot of technologies which are very promising is coming in the field. But again, in the future would be no aging.
I need to modify all of the times I talk about age now as a non-modifiable risk factor.
Exactly,
Gonna have to start changing the way that's framed.
At least non-modifiable for now,
Yeah.
which will be very modifiable in the future because they are reversing age as well. It's not only like stopping the age, but these technologies are reversing age. It's a multi-billion-dollar market. If we Google it, we will see.
Yeah.
But
Oh, Dan.
we're not there yet. The geroscience and gerotherapeutic world is hot, and it is targeting this population. But mice are living longer, but maybe dogs. But I don't think it's premature to say that in 2050 we're not going to have aging anymore.
Yes, sir. It's 2050 is just an approximate number. One of the person who was like really into this, Altan CEO, he has a target of reaching this human thing by 2050. But again, like Elon Musk trying to do a car which goes around without any humans, that the target gets pushed forward and forward, right? So it may be 2060, 2065, but just having this idea of, okay, age can be stopped is like 300,000 years of human evolution, right? We are in the brink of breaking it. Like we are talking about 20 to 40 years, not 300,000 years, So big change, the exponential change in technology growth.
I think it might get pushed forward until those researchers die, and then unfortunately it might not happen. I don't know. I'm not as convinced on that, but I am much more of a practical thinker, and I really think about the joining of emotional factors with technological factors, right? So it's like, can you prevent mitochondrial aging? And, can technologies, wearing a jacket, help to be able to detect what you want? It's like, maybe. I also know that my wife's 100-year-old grandfather, thank God, may he live and be well, does not have Wi-Fi in his house. He does not want Wi-Fi in his house. He doesn't want an Apple Watch. He's good. The only thing that he wanted was a little video display so that he can see pictures and videos of the grandkids that's on repeat, and he loves to watch that before he goes out shopping and does his other stuff. And if we would try to convince him to get additional technology into the house that he doesn't want, he doesn't want it. So, there is this emotional part, connections, the human aspect, and I think the more that technology is facilitating the human aspect and the more it's augmenting the ability to work together as a whole, the better it will be. So I don't see a future that is just technology running, in this way. I don't see it as stopping mitochondrial aging stops aging. Right? It's like there's a difference there, and somehow putting the two of them together is part of this future that needs to happen. And so I really see more of this cardiovascular, geriatric care being this fusion of additional technology, which is accounting for perhaps patient autonomy and families in the human-centered care coming together to be able to really care for patients in the way that they want to be cared for, and then allowing for this augmentation and in the ability to care, both from a clinical perspective and from a family and patient perspective, that allows for humanity to be reinfused into care.
Yeah, I'm so glad you brought that up because this individualization component is so important, and a lot of studies right now, when we're looking at the efficacy of these digital interventions, there needs to be more tailoring that takes place, right? There's not this one size fits all.
Yeah, look, I think fundamentally, better heart health is going to become part of, like, it's a fundamental derivation of behavior change. And right now, if you take a look at our society, people are relying on someone else to take care of them instead of them taking care of themselves. And so how do you empower a patient to all of a sudden have health that's top of mind? And that to me is the future of where health needs to be going. It's much more holistic. It's the fact that we want to be healthier for longer. And, you know, yes, there's a ton of research being done on telomeres and, you know, epigenetics and everything that's happening to extend lifestyle. But there's also the Blue Zones research, which is all about community and, you know, driving those types of things forward. So for me, the future of heart health is about cutting through the noise. This was kind of brought up on actually the panel before us, like how much data there is out there. And while it's great there's a lot of data, that doesn't necessarily lead to a lot of insights. And so how do you take the next step to empowering a patient to not just see their data and see that something's out of range, but see their data and know that, oh, I really need to be eating differently. Oh, I really need to go exercise, and to be empowered to feel like they can do those types of things. And that's what's going to make for a healthier society.
So let me put the brakes on this driverless car. So let's come back to today. My dad just turned 92, and you know, muscle health and mental health are two of the most important factors, at least from that age group, that continually are something that children have to deal with when you're caring for an aged parent. So I go back to a book that I was pointed out to, Remaking the Front Porch of America. It's about how communities get together and how you use your creative juices to keep your body and your mental being in good state. I think that's where most of our efforts, at least from a community giving perspective, has shown some dividends. Doing health screening or engaging elderly folks in activities, just looking over the fence and saying hello to their neighbor, or going to the nearest art center or a community center and exchanging hugs or shaking hands. Those things are in and of itself, you know, great therapies, but can cumulatively help. So I think that going back to that is certainly
That's technology.
A non-context aware announcement right there.
This is why interruptive alerts don't work. Love, not alerts.
It wasn't a short message either.
No, it was not. I was going to say, pause that for a second. It was several. I'm glad you brought that up because I think that a lot of times the perception, and oftentimes it can be a misperception, is that technology is getting in the way of that face-to-face or building communities, caregivers and their loved ones. And so I think you brought up some good points, and maybe others have comments to build off of that on how technology can actually be used to enhance your network and your community and really improve health outcomes for individuals.
I completely agree. You know, the best way to use technology is the user does not even know. It's like the hospital announcement. They do it 3 times probably. Code blue kind of, you know.
My apologies.
Dismiss.
Snooze.
I don't have that kind of power. I'm just the moderator.
I thought you were a nurse leader. You can dismiss alerts without reading them or listening.
Alert fatigue is real. Go ahead.
So going back to the thing, so the way to develop technology is to develop it so well that the user doesn't even know there is a new technology.
Yes.
That's what Steve Jobs did with Apple.
Yeah.
You just give an iPad, there is no need for any kind of manual, there is no need for like 80-year-old, 90-year-old use iPhone and iPad without a manual. If we bring healthcare technologies in a so smooth way that the person doesn't even know it's iPad or technology or a real phone call or a human phone call, then it would be all fine. You know, that should be the idea.
Yes, and I think that using machine learning and some of these other technologies for the data analysis can help with some of the issues that come up that were brought up in panel one of a patient who's coming into an office. You've got 18 minutes, and they're showing this report and these numbers that are really meaningless and taking up time. And so if so many of those things can be automated and almost to the point where the user doesn't even see that granular data, we might be able to solve some other issues that have been coming up.
Vijay, you are a self-driving car kind of guy. I don't know. Your vision works until Gemini tells the student to kill themselves, which is what happened a couple days ago. It's all over the news, right? So having these, like, you don't know if it's a real person or an AI, works so well until that mistake happens. Whereas if you know that it's an AI and you still have the ability to augment, suddenly you're able to account for that even when it does happen. Gemini is able to provide such benefit, even with that I read through the thread. It was horrible. It was horrible, right?
I read it through too. Just like it ends like you're a disgrace to the universe.
I couldn't
you
believe
should
it.
like die now. We don't know how the thing happened. Definitely it can happen. AI has got two sides, right? One is all the positive things we are discussing, and always there is this Terminator side. You know what I mean? Like, is it going to be like really bad that it's going to turn against humans? That risk is always there.
Or something
How
in the
we are
middle.
going to, how we are going to
The
mitigate
Skynet
risk.
fear.
Yeah, Skynet fear. How we are going to mitigate the risk and make it user-friendly and usable in an appropriate way to the community is a challenge. That's why we are all here.
Right. I mean, the way
we are
that
the pioneers.
the way that I think about it, like my name is Yair. That's YAIR, right? So you have to basically surround AI with humanity.
Yeah, amazing.
My parents thought of that. I didn't. So
Sure.
I mean, they named me. So
Very future
right,
thinking.
you really have to have this combination of the two. It's like when you think about, can you form community with technology? Facebook, great example, right? Everyone that uses Instagram is so much better. Their mental health is so much better. No, of course not, right? It's like it can drain you into losing your aspect of real humanity unless it's positioned in the right way. And, even Instagram and Facebook, they're doing their work now to kind of go back and try to help in the moment. But people didn't realize in the beginning what kind of an effect it would have. So, right, it's like it's the same idea of having all this technology in front of you, but losing sight of what is true humanity, what is true community, and then allowing for the two to fuse in a way that's positive.
Yeah, I mean, technology can absolutely help connect people. Okay.
This is a new level. They are turning the lights off. Well,
And technology can also get in the way.
yes, it can.
So it's about everything in moderation.
It is, and that's how I was going to conclude, actually, right? So good and bad. We obviously can see how technology has all these advantages, and yet we can't just turn everything over to that, right? It's a balance of the human and technology. So
Technology's in control.
in control. I want to thank everyone for being here. Really appreciate it. Yeah. Epic, Pat. That's it.